Okay, everyone, thank you so much for joining us for this webinar, Back to School Myopia Management for the Independent Practice with Dr. Rupa Wong. Initially, we had Dr. Jeffrey Cincino scheduled to join us for this conversation, but unfortunately, he had a last-minute urgency, so we've had to postpone his participation. But anyway, our apologies for this. We do want to notify you that we will notify you when there was a reschedule. But tonight we do have the honor of speaking with Dr. Rupa Wong of Honolulu Eye Clinic. And Dr. Wong, I've worked with for a number of years, and she's a board certified ophthalmologist. She has a specialty in pediatric ophthalmology and adult strabismus. She did her undergraduate degree at Duke on a very prestigious Duke scholarship, medical school at Cornell University Medical College, and residency at NYU. She then moved to Boston Children's Hospital of Harvard for her fellowship in pediatric ophthalmology and adult strabismus, and stayed on as faculty. Eventually, she and her husband is a fifth generation Hawaiian native, and she and her husband, who's an ophthalmologist as well, moved to Honolulu and started the Honolulu Eye Clinic, where they've been working for over 15 years. She's featured on the Best Doctors list since 2010 and Honolulu Magazine as well for that issue. She also works as a clinical associate professor at the University of Hawaii School of Medicine and is a mom of what she calls 3 potentially myopic children, although she may be more confirmed in that now. And she serves a large Asian population given where she lives. Dr. Wong is very passionate about alarming global growth trends of myopia in children and is a strong advocate for myopia management. So Dr. Wong, thank you so much for joining us today. And I also want to let you know that, we really appreciate your time, and, please know that I think everyone on the mainland has Hawaii in their thoughts and prayers right now during this very difficult time with the fires in Maui.
Thank you, Genevieve. It's really meaningful, and I appreciate those words and for the nice introduction. Hello, everyone. I am Rupa Wong. I am a pediatric ophthalmologist in private practice here in Honolulu, Hawaii, and I have been an advocate for myopia management since 2014 when I started seeing the ATOM studies, and we'll discuss that and why I am feeling very, very passionately about this and how I then utilize the lens star in my practice to grow my myopia management practice, as well as just to care for children in the absolute best way possible. Right. Let's do the next slide, please.
Okay. Dr. Wong, are you seeing the correct slide or?
No, I'm only seeing the main slide there.
Oh, okay. Hold on one second. Let me get this fixed.
There we go. There we go.
Okay.
Okay. I have been here in practice, as Genevieve mentioned, for over 15 years. We just marked our 15-year anniversary. And because I'm in Hawaii in the middle of the Pacific Ocean, we do take care of a large number of Asian patients as well as Asian mixed patients. And that's important because of the prevalence of myopia. 28% of the world's population was diagnosed with myopia in 2019. And it's estimated that by 2050, that number is going to grow to 50%. So by 2050, 938 million individuals will be suffering from not just myopia, but high myopia. And we know the statistics that in Asian countries, that incidence of myopia is even higher. So that's what led me to really start investigating myopia treatment strategies as an ophthalmologist, when most pediatric ophthalmologists, it wasn't even on their radar. And this is why I've become such a proponent of it. Next slide.
My apologies, Dr. Wong. I think we're having just a little technical difficulties, but we're getting there.
All
Hold
right, no worries.
on.
So in 1983, the average age of onset of myopia was 11 years old. I included a picture of my boys in this video, in that photograph, if we can go back up to that slide 6 there.
Yep.
Yeah, because my oldest was 11 at that time. And in 2000, the average age of myopia onset decreased to 8, which is the age of my daughter. And that is a big difference. And that 3 years, that really then impacts a child and their progression, as well as their eventual onset of high myopia, which is what we're all most concerned about and what we want to limit. This really is my why. These 3 children here that I have. My husband is of Chinese ethnicity. He has high myopia and has several retinal detachments in his family. He's had laser himself for some lattice and retinal tears. So that's why it's very important for me to be able to start recommending these treatments, because honestly, I started researching them for my own children and then was extending that to my patients. If we can go to the next slide.
Okay.
Perfect. And next slide. So the big thing that has really impacted the prevalence and the incidence of myopia was distance learning. The JAMA ophthalmology looked at the 2020 school year in its entirety. In China, they go from January to January, and they found that there was a 3-fold increase in myopia in 6-year-olds and a 1.4-fold increase in myopia in 8-year-olds. And this is a little video. I use social media, if you don't know, to educate, especially a lot about this topic. And this is a little video I had made with my daughter, who was 6 at the time. You can play it. I'm not sure if it'll play or not.
I don't understand. I don't understand. I don't understand. I don't understand.
So she had a hard time with distance learning, as most young kids did. But this is what most parents are very nervous about. So they come into you primed and already considering the impact of distance learning, the impact of screens. All 3 of my children have been given devices from their school, either iPads or laptops, to do their schoolwork. And there was a recent Wall Street Journal article that just came out, I believe 2 days ago, about the impact of the rising epidemic of myopia. They looked at the number of minutes children are spending outdoors, which is very minimal compared to what 40 years ago, as well as some of the new technology updates that can track these things. So parents are coming to you prime because this is now in the media. This is not just in social media, but in regular news outlets too. And so there is growing concern about the impact of these screens on children's vision and on myopia. Next slide.
I don't understand. I don't understand.
So risk factors. This is really what parents are going to come to you concerned. Time spent outdoors is protective. And so the inverse is, of course, true, that a very minimal amount of time spent outdoors is going to be a risk factor for the development and progression of myopia. Parental history, the amount of near work, and not just the number of hours, but some studies have found the intensity of the near work, if breaks are scheduled in between, may also play a factor. Asian ethnicity in some studies has also been found even separate from the environmental studying risk factors. And there's a whole subgroup of fast progressors. And these are the kids that we want to be able to treat for sure and start offering myopia management sooner rather than later. My kids had a lot of these risk factors. 1 and 2 risk factors. So when you have a child, if both parents are myopic, I tell the parents that there's a 1 in 2 chance. It's not 100%, but 1 in 2 chance that their child also will be myopic. When only one parent is myopic, then there's a 1 in 3. So I am presbyopic, my husband is myopic, my kids have a 1 in 3 chance. That just makes it simplifies it for parents so that they can just kind of wrap their head around these numbers and know if they themselves are myopic, they've had LASIK, they've struggled with this their whole lives, what is the risk to their child? And then 1 in 4 when neither parent is myopic. Again, not 0. And the modifiable lifestyle factors, the insufficient time spent outdoors as well, coupled with the prolonged time spent reading or on a digital device like smartphones, tablets, or computers. Next slide. If you do a quick lit search in PubMed, you will see there are more than 4,900 articles, almost 5,000 articles on myopia control. This is gaining a lot of traction. People are studying it and they are trying to figure out the best protocols and the best treatment strategies to use for our patients so we can start to stem this growing epidemic of nearsightedness. Next slide. So what do we have in our tool chest currently? Orthokeratology, soft contact lenses, either the peripheral defocus. Some people still use bifocal contact lenses in this regard. Low dose atropine treatment, just trying to modify those lifestyle factors like increasing outdoor time and decreasing near work. And then it's not available in the US, though I'm hopeful in a few years it will be, the spectacle lenses as well that halt and dims technology to be able to slow the myopia onset. Outdoor time, the benefits have been studied in numerous countries, and that's important because it's of children of different ethnicities. So China, Taiwan, Australia, I've seen studies in Denmark and Israel. And even moderate sunlight has been shown to be helpful at decreasing myopia. Just 11 hours a week is sufficient to decrease nearsightedness by 23%. And in this study, they even looked at just indirect sunlight. So it doesn't need to be direct sunlight. This is something I always advise my parents. The entire part of the conversation with parents is really educating as much as possible. I think there, with a lot of eye doctors, we grow concerned because some of these things are considered out of network or utilizing cash pay benefits. And really what we try to do is educate as much as possible so that they have at their disposal all the information they need to make the right choice for their child. And this is what I really try to tell them, that when you have a myopic eye, don't care how thick the glasses are, but what we're really concerned about is the risk of uncorrectable vision impairment. And that is, of course, going to increase the longer the eye is, the longer the axial length is. Only 3.8%, excuse me, for eyes that are under 28 millimeters, but 25% of uncorrectable visual impairment in eyes that are greater than 26 millimeters. So what we're trying to achieve with the LensStar is to be able to prevent future long-term sequelae and consequences of high myopia. Things like cataracts, glaucoma, macular degeneration, even vitreous syneresis and detachment, and then, of course, retinal detachments and retinal tears. And we see how sizably the risk increases when you go from low myopia to high myopia. So I tell parents, this is what we are trying to prevent. Even if we can't prevent them from becoming nearsighted at all, at least if we can stabilize it in the low or moderate category, that is a huge difference in risk stratification for their child. And next slide. For glaucoma, there is a risk of developing it, which is 50% higher in individuals with moderate to high myopia. That odds ratio is 2.5 for moderate to high myopia. It's only 1.7 for low myopia. And sometimes these tilted optic nerves can make glaucoma diagnosis very challenging and very difficult, may even delay treatment because of this regard. The risk of retinal detachment, again, 5 to 6 times greater in people with high myopia, an odds ratio of over 20 compared to those with low myopia. So if we can prevent low myopes from becoming high myopes, then we've really done a great service to our patients. And one last thing, the myopic maculopathy. This is what can be really potentially blinding for many patients. And you can see this odds ratio, again, related to the amount and dioptric power of the myopia. Myopic maculopathy, as I mentioned, leading cause of blindness and vision impairment in myopes. And it's the most frequent cause of visual impairment in elderly Chinese and in Taiwan. It's the primary cause of blindness in Japan as well. And most of the studies have looked at, they found that it is the most common reason for having impaired vision, and as well as not just in Copenhagen and in Asia, but even in Los Angeles. It was the third most common cause of blindness. And it happens young, average age 40. So this doesn't just affect the older age group. Cataracts are another consequence of myopia, and a large meta-analysis of over 38,000 patients from 12 different population-based studies showed that it is associated with both nuclear and posterior subcapsular cataracts. And next slide. So this makes cataract surgery then much more complicated, with posterior capsular rupture, retinal detachment as a result, even progressive myopic traction maculopathy, IOP elevation spikes right after, and capsular contraction syndrome. So this doesn't just affect those of us that are caring for kids, this affects my husband who does cataract surgery. And just as a reference point, you can take a quick look at the axial length elongation. You can always go back to that slide if you need to. But the benefits of myopia control, yes, thank you. 24 to 26. There we see very little, that's the normal average axial length, very little prevalence of visual impairment by age 75. And this is with all comers. So this is the really examining the complex interactions of optical, retinal, and environmental risk factors. But when you've got a 30 millimeter eye or even a 28 millimeter eye, the risk increases substantially. And my husband has a very long axial length. This is why, again, I will talk about later what I have done for my own children in addition to my patients. His axial length, I think, is 28 millimeters. Okay. Now, a lot of parents are concerned about starting any kind of treatment that they don't deem necessary, whether it's eye drops, whether it's a contact lens that they sleep in, whether it's a contact lens that they just simply throw away at the end of the day. And there was a really nice article that looked at the risks and benefits of myopia control, and they analyzed the adverse events that would happen from contact lens wear, and what they found is that these benefits of myopia control outweigh any perceived risks or any actual risks as well, because of the risk of visual impairment. So they looked at the number needed to treat to prevent 5 years of visual impairment, and they found that it was of benefit. So this is something that I discuss with parents as well. So my experience, I've been talking about, I've been doing a myopia control, myopia management for almost 10 years now. I began using axial lengths in my patient population in about 2016, maybe even 2015, and specifically the LensStar myopia module in 2020. It really did change the way that I was able to talk about the treatment plan, as well as the effectiveness of my treatment strategies with parents. So I was we had the first clinic in the state to fit my sight contact lenses, which I offered to age 8 and older. And I even have more patients now in my site, as well as about 20 to 25 patients in combo treatment. So the age range currently that I have undergoing myopia management really for my site is 8 to 16 years of age, but I have kids as young now as 4 years old on low dose atropine, and I will continue it until I see stabilization until about 16 to 18 years old. And this is where also the LensStar really comes into play at dictating when I discontinue treatment as well. Get the next slide, please. So I have the LensStar 900, and then we do have this software, which I love, the iSuite Myopia, because it prints out these really wonderful graphs that I can hand to the parents so they can see what we're trying to achieve and where we're at right now. This is a little video. You can feel free to grab it if you want from my website, but this helps patients the children not be concerned or worried about what the measurement is all about. This is my daughter here being the model, and you can play that.
Hi, I'm Dr. Rupa Wong. I'm a board certified pediatric ophthalmologist, and you might have stumbled on this video because you are interested in myopia management. What does that mean? Basically, for children, if they are myopic or nearsighted,
You can pause
worse and worse.
the video now. But you can see my daughter mimicking everything I'm doing in the background. And at first I was going to just cut it and re-record, but I found that my patients, my little 4 to 12-year-old, 15-year-old patients thought it was hilarious. It was relatable. They loved watching her. And so this is the video I send to them before they even come into my door, is that they know this is what myopia management is. And look, she's not scared. And I encourage them to watch this with my daughter, with their own children, so they can see her. All right, next slide.
Hi, I'm Dr.
So let's take a look at the report that you get. There's a couple different boxes. You've got refraction, biometry, and then there's even a box for environment where you can put things like the genetic risk factors, if the parents are myopic, age of myopia, as well as even some of the other types of risk factors, all can be entered into the software to really get a robust picture of your patient's projected myopia. Get the next slide. So when we do the lines, you're going to see that there's different curves right here, and each of them relates to different types of treatments. So you can customize. I don't do orthokeratology in my practice. I don't do certain things. I'm going to remove that from what prints out for my patients. So you can customize the different treatments that your clinic does. And then again, just hand it to the patient. So you say, look, if we don't do anything untreated, this is the curve that your child is going to have. And this is the likely refractive error they're going to have at age 18 or 19. But if we start atropine 0.05% or atropine 0.025%, or soft peripheral defocus contact lenses, this is the expected treatment impact on that from that intervention. Next slide. And this is what I really love, is you can chart every single encounter. So we in my clinic do the axial length measurements every single 6 months. So we do a baseline measurement, and then we do it every 6 months. And when you can show the curves and how it is following the treatment plan, as opposed to where it would be if the child was untreated, this is really going to encourage compliance, because it's not easy to use an eye drop every single day. I know all 3 of my children are on the low dose atropine currently, and there are many, many days that we forget. But when I see, it's blipping up a little bit, or when I can show a parent, look, it's working, then this is very helpful in encouraging compliance and for them to just stay on the treatment protocol. Next slide. It is individually adjustable. And the very nice part is that reference curve overlay that you can see right there. So I like the addition of this. This wasn't in the earlier versions of the LensStar myopia, is that you can put in time reading, age of myopia. We know if the age of onset is younger, they are at a higher risk category with being a fast progressor, even time spent outdoors. So these genetic and also modifiable lifestyle risk factors can get entered to help create a more robust picture. Next slide. And so this is the report that you get. And I love that you can educate parents. I give them all 5 to 6 pages. It actually will print out recommendations that you want, and you can adjust it for what you want in your clinic. And I always feel more is better. So we'll go through, yeah. So it's a new approach. You can visualize, you can interpret, and then we can communicate the data of nearsightedness. So this is a new part that came out with the latest update, which is the age-matched myopia control. And it seems a little weird at first because we're used to looking at the curves which demonstrate stabilization because it's showing the increase in myopia. But what we have here is actually the delta, the change on the y-axis. So we're demonstrating that we are impacting the change in axial length, the change in refractive error from 6 months to 6 months. This is very powerful. So we're looking at the axial growth speed, and then we can show the yearly normalization as well as its progression. Next slide. And it's got 3 lines. You'll see the normative study references. So it's going to show age-related and culture-related emmetropic eye growth speed. That's there in the dotted as well as the green solid line right there. And next slide. And I really like as well the traffic light system that they have because it's easy to remember. I'm very forgetful. Red, yellow, green. Red means that we are concerned because it has not slowed down. It is picking up speed. We need to intervene immediately. Yellow shows moderate axial length progression, and then green is showing just the emmetropic growth speed. So we want to get our kids to the emmetropic growth speed. Of course, the eye is going to continue to grow. I tell every parent, of course, but what we want to do is to minimize it. Next slide. And then there's a full box with all of the comprehensive information located up in the top right. So this is a very nice addition to the studies. It gives you the axial myopia indication, the time span over which you're looking at, as well as the progression class and the treatment response. So it gives just a lot of information to the parents as well as to you, the clinician. So I have a couple cases. These are my patients. This is a 13-year-old male. You can see all of his, we've been treating him for, oh, that's okay. As we can go, let's see. So its axial length started, if you saw, it was at 26 millimeters. All right, so he's a long eye already. And you can see when we've been treating him since what, 2016 here. So we were able to pull a lot of data and show, all right, this is at least functioning and we are making a difference in terms of his treatment, because otherwise he would be a diopter and a half more myopic than he currently is. So we can look at the refraction progress. But again, I also tell parents I'm really concerned more with the axial length than even the refraction. And next slide. And that's where you can see we finally starting to get him down near the end here, out of the red traffic light, it more into the greens. So we're starting to get into the greens there currently, which is good. Where it takes a while sometimes with certain patients. We have to adjust dosages. We're adding treatment strategies, but this really guides my decision making in terms of when I add a additional therapeutic intervention. Next slide. So this, you can see kind of right here what we did, because we started him initially 2016. The data Adam was saying 0.01. Then when LAMP came out in 2020 or a little bit before that, that's when I increased and I saw he was continuing to increase. I increased him to 0.05. There was some hesitation. We tried earlier with the parents to increase the concentration, but the parents were concerned about the light sensitivity photophobia effects as well as the near work effects. And then we added on custom soft peripheral defocused MiSight contact lenses. That's what's available here and FDA approved where I practice. And we can finally see, look, it is making a difference. So this was a great graphic representation to show parents that we were finally on the right path. Next slide. Second case, also a 13-year-old. She's 15 at this point, but we started at 13. So she was a contact lens wearer, again, had been started on atropine 0.01 because we started many years ago, but was progressing despite being on atropine 0.01%. We did tell her that this was an off-label use of the MiSight contacts because she was at this point 15 and not 13, or 8 to 12, which is the FDA label indication for the MiSight. And we put her in a contact lens. You might be wondering about the actual contact lens prescription. We actually fit each child in our office and do an over refraction on top of the contact lens. We have a large trial set. So we're not just guesstimating or doing things based on vertex distance. We're actually fitting them in the office. So that's why it might seem, why did you only go down a quarter unit on the right versus a half unit on the left? This is what gave her the best vision. Next slide, please. And so again, you can see her axial length. She does not have a short eye. She has 26 millimeter eye on the right, 25.8 millimeter eye on the left. And can we go to the next slide? And then we can see the refraction progress. Finally, you can tell when she started to get treatment 2, which is the green, we're starting to see a little bit more of a flattening effect from her contact lenses. And next. And then really, I mean, so, you look at the top one, you're like, oh gosh, she's still like, getting worse. But seeing this bottom graph is really helpful for the parents using those age match controls and looking at that delta. Okay, we're again starting to get into the green. We're starting to get into the emmetropization. And this is how I use that. Once I really see some stability of the growth of the eye and kids are approaching that 16, 17, then I feel comfortable discontinuing the treatments, whether low-dose atropine or the MiSight contact lenses. If I'm still seeing elongation and progression of the refraction, then I tell them to hold the course. Next slide. You can see the atropine 0.01 and the 0.02%. So what I do, I know a lot of people are concerned that this is always going to increase chair time. But the nice thing is if you are educating well, and especially the Lens or Myopia module allows you to do this, then you can really give parents a very visual method for extrapolating their child's eye growth, as well as see what their subsequent myopia is going to be if untreated and the effectiveness of treatment. And that alone then decreases your chair time and decreases, the discussions because it's right there in front. Next slide. I give every single parent the printout, as I mentioned, the 5 to 6 pages with everything. They walk out with that every 6 months. And I will test a child if I notice that they have an increase in elongation of -1.0 diopters over the past year, because oftentimes that in and of itself is enough to convince parents that we need to start considering myopia management strategies. Please feel free to reach out. I am all over social media. I have a podcast. I'm on Instagram and TikTok. If you don't know, I also have YouTube videos, a whole playlist on kids and myopia control and nearsightedness. But if you have questions or just how to create content for your patient base or just have questions in general, please feel free to reach out. How to institute myopia management in your practice effectively and efficiently. I think the efficiently is always key. Please send me an email. I'm happy to chat. I also give all of my patients, I create an online course for them called Preventing Nearsightedness in Kids, and it goes through 10 modules and videos and slides where I go through this research with them so they can look at, do I need to start my child on vitamin D? Data says no, but I go through that with them, red light, everything, so that they can feel empowered. So every single one of my patients gets that instructional course as well. So if you guys have questions, please let me know. And thank you so much. That is the family.
Oh, thank you so much, Dr. Wong. Such a beautiful family. And thank you so much for your words of wisdom on myopia today. Definitely learned a lot. We do have a couple questions, if you don't mind. Looking through the chat, one of the questions is, do you baseline axial length on pediatric patients with risk factors but no myopia yet, or how do you do that?
I do. So I am very cognizant of pre-myopes. So that's a discussion. I am training an optometrist right now that's a discussion that I tell them, look, this is a 4-year-old, but they're only plus 0.5 for their cycloplegic refraction. This is a pre-myope. Actually, all 3 of my children are pre-myopes. Knock wood, they are still pre-myopes. They are not myopic yet. That is because I started doing low-dose atropine for them at a very young age when I saw they were pre-myopes, that my daughter was not as hyperopic as she should be. So yes, for certain individuals, I will baseline, especially if I have parents that are really want to be aggressive about myopia management. They are a -13 or a -15. Of course, you know, in a very busy clinic, unfortunately, things don't reimburse as well. You know, that is a discussion to have with patients as well, but I do recommend it if it's possible. I at least bring it up to the parents. Say, this child should be a lot more farsighted. There's a risk they're going to become myopic. What's your number? And then we have that discussion.
Okay, great. And this leads into the next question is that this doctor's asking, you know, there's patients where the parents really want to get ahead of myopia. You know, they're plano, but the parents are high myopes. You know, what do you do? Where do you make that decision?
I personally treat pre-myopes, and that's that emmetrope who should be hyperopic on a cycloplegic refraction, right? That would be the norm, given their age. That's a pre-myope. That's not really an emmetrope. They're emmetropic, but they're pre-myopic, and they have risk factors. And you look at their outdoor, you look at their parental history, you look at their amount of screen time. And so I have treated many patients in the practice where it's typically the older sibling that's on the low dose atropine, and then the younger sib comes through and is, oh, they're only a plano right now, and they are 6 years old. Let's start treatment with the low dose atropine and see what we can do. So I personally recommend. Now I know that is not standard of care, and there's a big debate. I'm going to be presenting at the American Academy of Ophthalmology where we talk about this specific debate, but many of us are now doing this, and I think it's changing, because if we have the opportunity to prevent myopia completely, or even really just keep it at such a low number instead of a moderate number, I think we're doing a disservice to our patients to not have the discussion. So I at least have the discussion. And if I don't have time, if I'm busy, because I am busy, I have a folder with all of the information. And I just, you know, look, I'm a little concerned. Here's information, take it home, read it. I have a myopia management coordinator. She is a virtual tech. She lives in Oregon. I live in Hawaii. They can email her, they can text her through a HIPAA secure portal, and they can get more information and decide if they want to proceed.
Okay.
I hope that answered your question.
Excellent. This next doctor, you know, is reading a little bit that the atropine at a low dose at like 0.01 maybe isn't very effective right now. And is it okay to start at that, or, you know, are you comfortable talking about what dose of atropine you are comfortable with, depending on the patient?
So because of the LAMP study, I shifted the way the 2 cases I presented, just because of the longevity of the axial length measurements. You know, I had started them probably back in like 2015 or 2016, when my protocol was to start everyone on 0.01, increase them as if they progress. I now do the opposite because of the LAMP study. So I now start everyone on 0.05%. And if they are intolerant, we check in with them a week later if they are having any light sensitivity, because we are in Hawaii, they are outdoors all the time.
Yep.
Or they're having reading difficulty, then I titrate it down. Now, I know that one of the studies that just came out, the CHANCE study, which I have talked about before, showed that interestingly in their FDA trials, the 0.01 seemed to be more efficacious than the 0.03, which was interesting, and they had some thoughts as to why that was. I still am going to continue with my current protocol of 0.05, but that is, again, another debate, I think, within the community. I've heard from other pediatric ophthalmologists that think, well, if they don't respond to the 0.01, that means they are a non-responder, which I think that's an interesting thought. They're not going to therefore respond to 0.05. So you don't even need to try that. You should switch modalities or add a combination or do something else. So no data, no studies yet on that, but anecdotally, that's what I do.
Oh, great. A couple of the questions are really coming into reimbursement. I mean, we know that there's not reimbursement right now, and it's, there's some hesitation on presenting these fees to parents. And I know, you can't talk about specifics of what you charge, or if you do global, or what kind of fee schedule you have. But what's most compelling for you to talk to parents about the investment in myopia control and management for their children?
So I think for a lot of parents, and not every single parent, I know that the entire cost of treatment can be expensive and there are inequities in healthcare. But for many of them, one of the parents is myopic, and typically many of them have had LASIK or PRK, at least in my particular patient population. So when I equate it to, listen, you spent $5,000 on your LASIK, but you know what? That retina is still, I don't say damaged, but I basically am insinuating that retina is still stretched thin. You are still at risk for retinal detachments and retinal tears and cataracts and glaucoma and myopic maculopathy. Can you imagine if you could reverse 20 years and just not be as nearsighted, not be as concerned about visual impairment for your child? So that's how I present the information. I compare it to what they might be paying also in terms of glasses, or the glasses updates, right? Every year, if you can stabilize it, that's going to be a little less expensive. Like, all of those things is how I present the information to the parents, so that they can kind of put it in a bigger picture and look at the child's myopia over the course of the 18 or 20 or their entire lifetime, and what cost that would be.
Okay, great. Thank you so much. For the other questions, we run out of time, but we will definitely get back to you via email. So thank you so much. And I want to thank everyone who joined us today for a fascinating talk. Dr. Wong, thank you. We really appreciate your time and and your indefatigable energy with battling myopia. It's really appreciated. It's really inspiring.
Thanks, Genevieve, so much for having me. I always love having an opportunity to spread this message and educate as much as I can.
Okay. Thank you so much.
Bye-bye.